Welcome to GU Oncology Now. My name is Shifeng Mao. I am a medical oncologist, practice at Allegheny Health Network Cancer Institute at Allegheny General Hospital. Today, joining with me a panel of my colleagues from medical oncology. We will discuss about prostate cancer and recent development.
I'm Dr. Casey Moffa. I'm a medical oncologist with Allegheny Health Network in one of the community sites at Wexford.
I'm Moses Raj. I'm a medical oncologist affiliated with Allegheny Health Network. I have practices at Allegheny General and AH and Wexford Center.
I'm Alex Helfand. I'm a genitourinary medical oncologist at Allegheny Health Network Cancer Institute. I practice at Allegheny General Hospital.
Bushra Haq, a medical oncologist with Allegheny Health Network.
As a medical oncologist, in recent years, there's an increasing trends of metastatic prostate cancer making to the doors of medical oncology. And it is a disease used to be seen mostly by urologists, but in recent years, we've seen a lot of metastatic prostate cancer. So when you see a patient with newly diagnosed with prostate cancer, what's your general approach? And just a general question, Dr. Raj.
So, we work with the urologist closely and confirm the diagnosis of prostate cancer. Once we get the diagnosis, we look at the Gleason score and then also trend the PSA. How is it behaving? And then we usually start the workup. We are in close cohorts with the urologist and see what the general plan is, whether it's localized or metastatic. Obviously, to start with, most prostate cancers are hormone-sensitive, and then the workup begins. It's done in close coordination with the urologist in a tumor board setting sometimes. At other times, we initiate the workup ourselves.
So prostate cancer is #1 cancer for men and second killer for a man with cancer. And how do we tease out the dangerous prostate cancer from all comers? Dr. Helfand.
There are a number of sort of strategies that we can use to risk stratify patients. So certainly one is by looking at the pathology and assessing the Gleason score. There can be other features that can also be suggestive of higher risk that may include perineural invasion or lymphovascular invasion. Another important thing to remember is that not all prostate cancers are adenocarcinoma. A small percentage are neuroendocrine prostate cancers or small cell cancers of the prostate, and it's important to make sure that we assess those. And then we also have, in the setting of metastatic disease, we have high-risk criteria as per the Latitude trial, which includes Gleason score as well as the number of bone metastases as well as visceral metastasis. And so by putting those features together, we get a sense of the risk of the patient progressing more rapidly and or being resistant to primary treatment.
You kind of touch upon a little bit about the high-risk pathology. Just want you to expand that a little bit. When you look at the pathology report, what are the high-risk features beyond Gleason score?
So when you're looking at a surgical specimen, for example, then you are looking for what might upstage the patient. So extraprostatic extension. Is there invasion of the seminal vesicles? Is there any evidence of invasion into the bladder neck, for example? You may also assess, is there, and whether there's invasion into, the rectum or the pelvic sidewall. A lot of times with a metastatic diagnosis, we don't necessarily have, full pathology in the event of de novo prostate cancer, meaning prostate cancer that where the patient presented with metastatic disease. But certainly we, have information from biopsy. We have information from imaging, and then we also have molecular information that can also guide prognosis.
So In addition to the Gleason score high-grade disease, you mentioned about perineal invasion, extra prostatic extension, and bladder neck margin being positive. Those are high-risk features. What about some detailed histology such as cribriform pattern, intraductal carcinoma? Those are high-risk features as well.
Very much so, yeah. I mean, so intraductal pattern, or ductal prostate cancer as opposed to acinar prostate cancers, are typically higher risk for progression. And then cribriform features, which refers to essentially this pattern of circular structures on the pathology, essentially under the microscope, is also a higher risk feature. The reason that becomes somewhat relevant both in terms of risk stratification, but also because those are conditional indications for doing germline testing, because patients who have those features, and this is in the earlier stage setting, but patients who may have lower, who may have localized disease but still have cribriform or intraductal features, still have a higher rate of germline or inherited cancer predisposing mutations than patients without those features.
So, Dr. Moffa, Dr. Helfand mentioned about germline testing. And when do we do germline testing when we see a prostate cancer?
I would typically do germline testing if there's obviously a strong family history. I mean, like we would do with most malignancies, if there's multiple family members with a similar cancer type, we check for basic germline testing. And then, I mean, also, as he was mentioning, if you're seeing on the histology that these are tumor types that aren't as, mainstream typical adenocarcinomas, you should also raise the flag that we should be making sure that we're doing germline testing. I think you can also think about if there's beyond prostate cancer in the family, if they have other type of multiple family members with other forms of malignancies. Is there more breast, ovarian, pancreatic, that these are patients we should be considering to have testing done?
So what do we look for from germline testing in prostate cancer?
Well, BRCA, with BRCA1, BRCA2 gene mutations are the two, I think, most common ones that we would see. Beyond those germline mutations, I mean, I don't know if there's any other specifics. I don't know if Dr. Helfand would probably know.
Yeah, I mean, BRCA2 would be certainly the most common, and then mutations in ETM are fairly common, as well as mutations in CHEK2, PALB2, RAD51A and B. Those are the more common homologous recombination deficit-related mutations. But there's also patients who present with Lynch syndrome and other types of predisposition syndromes that are less common but not identified unless we look.
So, Dr. Haq, when you decide to order a germline testing, what platform would you use in general? And do you test germline? Do you also test tumor DNA?
I do. If you have the biopsy available, I would like to test both germline and somatic testing. And then we have so many options for companies to do the testing. I don't have a particular favorite. I know our system at AHN, we have our own home test available.
That's but we also
In-house
use,
testing, right?
commercial vendors.
Right.
And we don't have to mention the name of the companies. Yeah, but the common vendors that we use. Go ahead.
Yeah, I was going to say, historically, patients who we were, doing genetic testing for, particularly for germline testing, those patients would get referred to genetic counseling. And it is always appropriate to refer patients to genetic counseling. The challenge sometimes, and this occurs, I think, throughout the country, is that it can be difficult for patients to see genetic counselor quickly. And so, some of us will order genetic testing ourselves and then counsel patients appropriately. Obviously, it's important to recognize that a negative result doesn't mean that nothing is present necessarily, and there are variants of undetermined significance and other, things that still require some nuanced interpretation. But, by getting these diagnoses early, we're better able to plan our treatment.